Bismillahirrahmanirrahim. I did not know Dr. Amir also has CTO RCA, otherwise I would have presented CTO LADR, CTO circumflex. I am going to discuss different algorithms that are used for CTO techniques. We have a patient, 54-year-old male, that presented with a history of chest pain on moderate exertion. This is his ECG, that is absolutely normal. He was advised ETT that shows STT changes in inferior leads, 2-3 AVF, you can appreciate. His echo was done, ejection fraction is pretty good, 55%. These are the images. As you can see, that LV is very good. So he was advised angiography after that. This is the angiogram that's showing moderately tight proximal OM branch, and left main is normal, proximal LAD is normal. That's retrograde filling of RCA. Here we can see with good collaterals, retrograde filling of RCA there is. These are the different views, you can appreciate all these views. Here is the RCA totally occluded with a lot of branches, proximal, total proximal occlusion. So learning objectives are definition of CTO, preparation of the, how do we prepare for this patient, the determinants, what are the determinants of success, and what are the advanced CTO techniques. So CTO is a lesion that is RT that is occluded more than 3 months by definition. So when you are planning, avoid doing ad hoc CTOs. Always look at the prior angiogram, plan to reduce radiations and contrast as well as fatigue. Consider viability scanning if ejection fraction is low. And always consider for dual injection as my predecessor has already mentioned. I want to mention here the success rate of CTO PCI is significantly improved during the past decade from 50 to 70% to 85 to 94% at the experience centers. These are the different algorithms being used all over the world. The first and the foremost is hybrid algorithm, which Dr. Amir has already explained. Other is Asia Pacific CTO Club China, Japan CTO Club, Euro CTO Club, and the last one is Global CTO Crossing Algorithm. Hybrid algorithm emphasizes the importance of dual angiography. It recommended a prompt change of strategy in case of failure to achieve progress, and awareness of radiation and contrast use and procedure time. And Asia, I have mentioned few, I'm not showing you all the algorithms, but it will be confusing. I have mentioned the few lines. Asia Pacific CTO group, it recommends the IVUS to resolve the ambiguity in the location of the proximal cap and use of the cross-boss catheter. CTO China group, it says that if proximal cap is tapered, then antegrade, otherwise go for the retrograde if you have good collaterals. And Japan CTO Club, changing from antegrade to retrograde after 20 minutes of guide wire manipulations. And Euro CTO Club says that IVUS or move the cap subintimal technique first, followed by the retrograde technique. And the last one is Global CTO Crossing Algorithm. These are few words about Global CTO Crossing Algorithm. It was created by a group of 4 CTO PCI experts from North America, Europe, and Asia. A total of 122 other CTO PCI experts from 50 countries were invited to participate, of whom 121 from 50 countries provided comments and approved this final document. It's a 10-step strategy. If we memorize and go through these 10 steps, CTO algorithm is easy for us. The first and foremost is dual angiography. Always attempt CTO with dual injections. Planning is very important for CTO. And step 2 is careful angiographic review. Proximal, whether proximal cap is ambiguous, what is its morphology. CTO, look for the CTO lesion length and composition, and look for the distal vessel quality, collateral circulation. And the third point is approaching proximal cap ambiguity. If proximal cap is ambiguous, how do you approach? Stiffer tip wires should not be used initially to puncture the caps. And it can be resolved if the cap is ambiguous. This ambiguity can be resolved by taking different views or doing CT angiogram first before going for PCI. And step 4 is approaching poor distal vessel quality or bifurcation at the distal cap. If we have distal vessel quality is poor and there is a bifurcation at the distal cap, go for retrograde approach. It's safer in these patients. And step 5 is feasible retrograde option. We should look for whether it's feasible or not. We will look at the interventional collaterals feasible for crossing. There are 3 types of collaterals: bypass grafts, septal collaterals, and epicardial collaterals. Epicardial collaterals are the last one which we will attempt. We will try to go from the septal or the bypass grafts. And step 6 is anti-grade wiring strategies. Start with the low tip tapered polymer jacketed guide wire. These are the steps. If we follow these steps, it will be easy. If it's not working, then we may escalate to the stiffer polymer jacketed or high tip load wires that should be tapered. And if we have gone to the escalation technique, and escalation should be followed by the de-escalation. If wire fails to enter in the distal true lumen, parallel wiring technique, device-based re-entry, that is the stingray balloon, and or the IOS guided anti-grade wiring should be done. And if all of this is not working, anti-grade dissection and re-entry may work. It should be done in those patients where there is the lesion length more than 20 millimeter, it's calcified, it's tortuous, and presence of appropriate re-entry zone of large caliber and without major side branches. 7th step is retrograde approach should be done for those patients who have ambiguous cap and bifurcation at the distal cap, and when anti-grade approach is completely impossible. Always try to go with the anti-grade approach. If it's not working, then look for the parameters for retrograde approach. If they are there, then go for that approach. And we should keep in mind, step 8 is we should keep in mind that if our one strategy is not working, we should immediately go for the other one. Because one experience again and again will not work out for us. And step 9 is sometimes we do investment procedures. We do not go for the 100% success. If crossing attempt fails, different investment procedures may be considered if benefit is more than harm. We can do balloon angioplasty of proximal cap and wait for the 2 months to re-attempt to heal dissections. And step 10 is we should all know that when we should stop. If the procedure time is more than 3 hours, contrast volume more than 3 times the estimated GFR, air karma radiation dose is more than 5 grays, and if advanced crossing techniques needed but operator doesn't have its experience. And significant operator or patient fatigue. If you are fatigued, then stop the procedure and plan it next time. These are the 10 steps we should follow, and these are it is the consensus document. This is the algorithm of all those 10 steps given in this paper. This is a brief description of the CTO wires. JCTO score, in our case, JCTO score was more than 3. So we started our angiography, we started with the dual injections. We took the right access, RCA access with XB RCA and left JL4 guide. Looking for the lesion length. I will show it quickly. So we started with microcatheter and fielder XT wire. It could not cross, so the other wire which we had available in our cath lab, that was that was, sir, I think CrossFit 100. It was CrossFit 100. So we started with then CrossFit 100. It crossed. We were looking again and again with our dual injections. So we are in the lumen distally. We pre-dilated. The other procedure is simple. We pre-dilated, then started stenting. This is the distal stent. And then distal to proximal we stented 2.5, 2.75 millimeters. These are the different stents. I will show you quickly. This is the final result. Here we can appreciate one point in the mid-distal portion which we could not dilate even with the higher NC balloons, going up to 20 millimeters of mercury, 20 atmospheric pressure. So this is the final result. Thank you.